Hello, I am Flavio Ribichini, and I am very pleased to welcome you all to this webinar organized by PCR and supported by an unrestricted grant from Medtronic dedicated to drug coating balloons, DCB. And this is entitled Why and When to Use DCB. The objectives of this meeting today are to discuss why a PCI strategy without implantation of metallic stents may be a valid alternative which is the supporting evidence. To understand what kind of patients and anatomies a DCB PCI may offer advantages over conventional stented PCI, and to observe, and this is very important, the long-term result which is specific of the DCB-based PCI. To do that today, it's my pleasure to work together with a wonderful team of colleagues and friends that have joined me here in the studio. Dr. Dejan Milasinovic from Serbia, he actually is here present, but due to some problems with communications and strikes, Professor Bruno Scheller from Hamburg, Germany is joining us remotely. Welcome, Bruno. And for obvious reason, Dr. Tiong Kiam Hong from Kota Samaraham in Malaysia is also connected with us, although it's late in the evening for him. Thank you very much for joining us and sharing your experience with us. So, with no further delay, I will start with the point of this webinar. Why using DCB? Bruno, you are the father of this technology. You are the most expert in the group, and you have done basic research and clinical trials. So let us know which are the basis of this evidence to support the use of DCB.
Thank you, Flavio. I'd like to start with the question, which is the best drug for local drug delivery when using DCB. And you know, we are talking about sirolimus or paclitaxel, very similar to the drug-eluting stents. And the big advantage of paclitaxel is that it has an irreversible binding to the microtubes in the cell. This means you have the chance with a one-time delivery to have a very long biological effect, and that's the beauty of paclitaxel. Next one. Next. And what's very important is, and this is the first animal experiment we published in 2004, is the fact that it is not enough to have the right drug on the balloon. You also need additional agents, excipients, like we say today, to guarantee that the drug is not washed out in the blood on the way to the lesion. And if you have contact with the lesion, that you have a sufficient transfer of the drug to the vessel wall. And we started with iobromide, the contrast molecule, as excipient, and found a dose-dependent effect. And later on, other excipients like urea here were also suitable for drug balloon coating. And as you can see here also is that the sweet spot is paclitaxel concentration of about 3 microgram per square millimeter balloon surface, with the biggest effect in inhibition of neointimal formation, and at the same time, no further toxicity. Next one. And what we learned from the first clinical trials was that it is a very efficacious treatment, but it is very important that you do your job in lesion preparation. And this is, for example, an analysis from Korea on the treatment of in-stent restenosis. And what you can see is that you have to obtain the best initial result with a low residual stenosis. Here, 20% was the cutoff. An adequate sizing of the DCB and a long enough inflation time. And these are very important lessons for the use. If you look at the European guidelines, the last ones are from 2018. We have a class 1A recommendation for the use of drug-coated balloons for the treatment of in-stent restenosis at the same level with second stent. But these guidelines also clearly state that there would be no room for using DCB in de novo lesions. And I think this is one point we have to discuss, because in my opinion, the use of DCB for the treatment of ISR is the worst indication for DCB. The advantages of DCB are in favor if you use it for de novo lesions.
Okay, thank you, Bruno. You said it's the worst indication, but this is well accepted in Europe, and it's a class A, 1A indication. Now we're going to move on what is the use of this device in de novo lesion, and why doing that? I mean, why do we think that this is an alternative? Let's see what is happening. How do we manage atherosclerosis? Atherosclerosis, through the history of balloon dilatation, bare metal stents who gave safety but very little efficacy, was very much improved in terms of efficacy with the use of drug-eluting stents. But as you can see in this slide, atherosclerosis remains there entrapped in the vessel, which is the ideal concept of delivering locally drugs that can inhibit proliferation and help vessel healing either by bioabsorbable scaffolds or local delivery of drug. This is the dream of treating atherosclerosis without leaving metal. Metal are very, very useful, but too much metal is not good. This is the 10-year result of the SYNTAX trial. You can see in green, in the overall population, how the mortality doubles when the stents are too long. And this is even worse when the patient have 3-vessel disease. And the other important message is the relationships in between mortality and stent diameter. The smaller the stent, the higher the mortality, and of course, the more stents you implant in 3-vessel disease, the higher the mortality. So why using DCB? Bruno, why stents fail and how they fail?
I mean, if a stent fails, there's a huge variety of possible reasons. We have stent-related factors, including under-expansion, under-sizing, fractures. We have differences between different stent types. As you know, the new generation DES have much smaller struts than the first generations. But we have also intrastent factors related to the fact that we have permanent implant. This is neo-intimal hyperplasia due to the injury. Neo-atherosclerosis becomes more and more a very big topic. In addition, there are extra-stent factors, as said. The more stents you implant, the smaller stents you implant, the more events you have. And this is a very impressive picture, for example, of a stent fracture, which is a rare event, but which cause huge problems in those patients.
Yeah, that's clear. And we have to compare against a very effective and safe therapy, which is surgery. We want to go very briefly on this paper, which was published by the group of Ari Kaptein some years ago. It's the 30 years follow-up, because it's very important, we think, at the long term. Look at which are the predictors of survival at 30 years. It's obvious. The most important one is age. The older you are, the more likely you are to die. But in terms of disease burden, of course, the severity of CAD. This is 1-vessel disease, is lower risk, almost no risk, 2-vessel, 3 vessels, left main, and left ventricular function. But if you look at the Kaplan-Meier on the right side, in red, you see the survival at 30 years of patients that have undergone surgery, which is almost identical to the black curve, which is the superior one, patients that had never had coronary artery disease. So this is the aim, to offer the patients the best clinical result at long term. But there is, Dayan, another subset of patients that do not benefit that much of metal and complex procedures, and these are patients with bifurcations.
Exactly. If you let me summarize what has been said so far in the first 10 to 15 minutes of this webinar, it's that the DCBs are out there. They are recommended for in-stent restenosis. In-stent restenosis is reality. Stent failure is reality. And we may aim to be better than fail with stents when this happens. And you showed very nicely a 10-year follow-up of the SYNTAX trial that small diameter stents and long lengths of stents pose a risk for those stent failure events and, of course, for increased mortality. Now, if this is a subset of patients, and I am new to use DCBs in native arteries, I've used it extensively in patients with in-stent restenosis, but to the native disease, I'm beginning. And if I think what are going to be the first lesions I'm going to treat, it's exactly what you pointed out. It's those lesions where I would actually implant stents which are small in diameter and long in length. So smaller caliber vessels with diffuse disease. And when you think about bifurcations, there are such bifurcations where you would need 2 stents and where, for example, a side branch would be long, diffusely diseased, perhaps, but small in diameter. And in such anatomies, you may start thinking, let's say, outside of the box, outside of the evidence base we currently have. When we think about the evidence base, and here you see it on the slide, this is what we have. Yeah. When you implant 2 stents in a bifurcation, this may increase mortality. And we have it from 2 sources, from 2 actually large studies. One is the extended follow-up of the Syntax trial, 10-year follow-up, which signaled an increased risk of mortality, especially beyond the 5th year, in patients who had bifurcations treated with 2 stents. And the second, in blue as well, you see the pooled analysis of the Nordic and the BBC1 trial, and this was a 5-year follow-up, also signaling a mortality risk with double stents. Now, a counter-argument can be, all these studies, both Syntax and Nordic and BBC, did not utilize the best of all strategies, and that could be DK crush. When you see in violet the DK crush evidence, it pertains mainly to complex lesions, and where DK crush was better was mainly in terms of TLR, TVR, and when compared with provisionally DK crush 5 trial, it was also better in terms of target vessel MI, but not mortality. On the left, we see an increase in mortality. So if you have an anatomy like this, is this an anatomy for a DK crush? I would not say so. This is a young patient who has many years ahead in life with a STEMI, ST elevation, lateral wall infarction, and an occlusion of a long but very small in diameter ramus intermedius, which is occluded in the ostial segment. So if you think about the key principles of bifurcation PCI, and that is to stent according to the distal diameter of the vessel, and aim for well-opposed stents with minimal overlap, this is how it would look like. So if you try to aim for the ostium, or if you protrude to the left wing with a small stent, it's going to be very problematic to achieve, I think, good results. So you may think outside of the box here, and in this kind of anatomy, try to treat the patient with a DCB. And this is what happened, and we actually did achieve a result which was initially very good. The patient did not feel any pain anymore, and we had an ST segment elevation resolution, which is exactly what you want in that kind of a patient.
Okay, thank you, Dejan. You make the point very clear, and this is a clear example of how it would be terrible to implant a stent. Before ending the first part of this webinar, which is dedicated to provide our colleagues the basis, we will make you participate later as soon as Bruno shows us the available clinical evidence of efficacy and safety of DCB at long-term result. Bruno.
Yeah, the criticism on DCB is, of course, that we do not have this huge database from randomized trials as we have it with the trach-eluting stents. But meanwhile, there are a large number of smaller or medium-sized randomized trials available. And as a reaction on this discussion on paclitaxel safety in the peripheral arteries, we conducted with an international group this meta-analysis on 26 randomized trials published until 2019, 4,500 patients. And what you can see is that with this concept of DCB only, we have a very low myocardial infarction rate compared to alternative treatments. This means the problem that some people say that the vessels occlude and we need stents that the vessels remain open. This is clearly not the case. We have a lower rate of myocardial infarction. And if you look at longer-term survival, cardiac mortality at 3 years, there were clear signs that the not using permanent implants may be beneficial for the outcome of the patient. And on the next slide, you see long-term data from one of the most experienced centers in DCB only, from Norwich in UK, Simon Eccleshall's group. And they published this analysis of 1,500 patients, either treated with current generation trach-eluting stents or DCB only. And here you can see very well that at a follow-up of 5 years, there was numerically higher all-cause mortality with trach-eluting stents than it was the case with DCB. With the stents, you have this ongoing event rate year by year, which seems not the case if you avoid a permanent implant.
Okay, thank you, Bruno. So this first part of the webinar is done, and I think that we have provided you with good evidence of which are the bases for using this therapy. Now I will go to the screen because we move to the second part, and this is probably clinically more interesting, and we want to know simply when to use DCB in native lesions. And to answer these questions, we have our iPad here, and we can address all your questions from home. So please start sending. We have already some good questions related to lesion preparation, because there are clinical scenarios in which patients might benefit from this therapy: high bleeding risk, patients with acute coronary syndromes, with STEMI, very young patients that will have progression of the disease, or old and fragile patients that come back to the first point, they might be high bleeding risk or very fragile. And anatomic scenarios like in-stent restenosis, we mentioned that, this is the only accepted indication, long lesions, diffuse disease, and small vessels, and as Dejan, you well pointed out, the bifurcations. So, Bruno, show us a couple of examples where you can absolutely convince our colleagues that this is the way to go.
So this is the case of a 70-year-old lady we treated in 2006. You know, we had the first results from the PACOCAT ISR trial available end of 2006, ready for publication, and there was a time between having these results and DCB not approved for clinical use, and we were allowed from our ethical committee to treat patients with recurrent in-stent restenosis and compassionate use. And this lady had full metal jacket in her LAD. This was another total occlusion of the LAD. The right had also several restenotic events, and all this LAD and right had several layers of metal. And we treated her with this first DCB, the prototype DCBs at this time. And from this time on, she was free from symptoms. She had one reintervention in the distal part of the LAD where we used only uncoated balloons. And from this time, she was free from symptoms and had a very good life afterwards. Another very important point for me is the fact that we have to say that DCB is not a replacement of stents, but is a tool to reduce the total number and length of stents. And this is a very interesting data from Korea. 500 patients with multi-vessel disease, either treated with a primary stent approach, that means every lesion was stented, or a DCB-only approach. This includes that you decide after your lesion preparation if this lesion requires stenting or not. And the first point is that about 1/3 of the lesions required stenting in complex diffuse multi-vessel disease, but 2/3 could be treated without stent implantation. And now you see in the next slide the outcome at over 2 years. And there you can see on this next slide that the event rates were much higher in the 100% stent group than it was in this mixed group with 2/3 DCB-only treatment and 1/3 stent treatment. And I think that's the way to go for diffuse disease in the future to improve our outcomes.
It's amazing results on this clinical study with treating patients with 3-vessel disease. We are getting a lot of questions now, and I think that at this point it's interesting that we make the question of lesion preparation. Bruno, you showed very well how better the results are when the lesion preparation is appropriate. Final stenosis lower than 20%, a balloon to artery ratio 0.9, close to 1, and at least leaving the balloon in place while releasing the drug for minimum 60 seconds. So this is answering some of the questions of the colleagues. Dejan, you are the youngest. Which is your technique? They want to know whether to use non-compliant balloons or regular compliant balloons to prepare the lesion before releasing the drug.
Yeah, well, I try with the non-compliant balloon, not to risk as extensive a dissection, but that is how I start. So I start with a non-compliant balloon, but I try to be 1-to-1 or almost 1-to-1 ratio. So non-compliant, as large as a stent would be, and then afterwards I decide on the DCB.
Second question, and this is addressed to you because it has to do with the case you showed. You showed an acute coronary syndrome. Would you be comfortable in using DCB in patients presenting with ST elevation MI?
Yeah, I mean, we need to be very honest here. So most of us, unlike Professor Scheller, who is one of the fathers of the technology, most of us are very new to using this sort of technology in native disease. In the absence of randomized evidence comparing head-to-head stents with DCBs in several subsets of those lesions, we are not going to have definite answers. However, anatomical and clinical considerations, as you nicely pointed out, will push us towards it. And DCB is a very, very handy option to have in the cath lab. So I'm not going to say I'm going to use DCB for all STEMI patients that I have. That's not going to happen. There will be situations like the one that I showed where I think it's wise to do.
Let's have a look at this situation because this is your patient.
Yeah,
so you said you are starting to approach this technology. Tell us why you decided to treat this patient in this way.
This is another acute syndrome. So imagine a patient around 65 years old with a previous history of stenting to the left coronary artery, and as you can see here, an ISR in the circumflex, presenting with an unstable angina that evolves into a non-STEMI. So this patient, over a week or two, has chest pain, which bothers him. He repeatedly goes to the hospital, and once the troponin actually was elevated, he's admitted to the hospital and angio is made. Now you see that the clearly culprit is not the ISR from the previous stent that was implanted years ago, but the native disease, the native subocclusive RCA distal lesion. So this is a lesion. You can say, oh, it's a small vessel, do not treat it. But it's an acute coronary syndrome. The patient has had chest pain without exertion, so in rest, and repeatedly, so he comes to the hospital. So what happens is that when you predilate, you have a question that you ask yourself. I have this kind of an anatomy in a fairly young patient with already a history of ISR. Am I going to proceed with a small diameter stent, and we heard this predisposes to a certain risk, or am I trying to use the DCB, for which I do not have the solid evidence base for these kind of patients, but anatomically and clinically it can make sense, especially if after predilatation I do not have a large dissection that limits the flow, which is the case here. I do not have a large dissection that limits the flow, and you see the result after the predilatation. So what can I lose if I try the DCB here? That was my logic, but let us see what you think and what the audience thinks.
No, I think it's a very good example to try to start with because you are in a low risk situation. I mean, you have a short amount of myocardium at risk. The patient had long time of chest pain. It's a small and distal vessel. So whatever it happens, the patient will not suffer big consequences. But at the same time, it's a very good test to look at the long-term result because if you put a stent there, the risk of occlusion or restenosis is very high. So the question to our colleagues now, this is our first question. We launched the question, think about, send me the answer, and I will say, who would consider this lesion for be treated with DCB? And while they answer, final result.
Yeah, so I would like everybody to think about this case because I was in a dilemma as well. As I said, it is an anatomical situation where I thought DCB could be handy, so I'm eager to see your responses to this question, and I think you can see them. You can see the question online and answer. This is what, in the end, I did. So I opted for DCB. It was a paclitaxel-eluting drug-coated balloon with there was a 2.5 in diameter, and we applied after predilating with an NC balloon the drug to the vessel wall, and it's on the left side. I was unhappy. After this tortuosity, you can see some haziness. I wasn't sure whether this was a dissection, whether I should have used a longer DCB to start off. So what I did is I passed another drug-coated balloon across the already applied segment and then applied the drug to that segment that is more distally. And you see here the final result. And then you see the result after 5 months. So we called the patient back and we said to the patient, okay, we want to see an angio again. It was a new methodology we used. And I think this is a very important point. I think that when we introduce new technologies parallel with data acquisition and randomized studies that are ongoing, I think we also have a sort of an obligation to follow up these patients more closely. And what I try to do in these situations is, if possible, of course, to have a follow-up angio. And you see here, the vessel looks better than initially at the final result.
Yeah.
It's larger, it's like positive remodeling, and the vessel definitely is open without any traces of problems on angio. So if you compare this, and we go back, so if you compare this with the situation on the left artery, which is what we did. We took a shot of the left system as well. Here you have a progression of the initially observed in-stent restenosis, and you have an in-segment restenosis, which is severe, which is something we know is possible when having acute coronary syndromes.
So, Dayan, it's a nice case because it makes you believe on the therapy. You are starting to use it, and it's a good advice. I mean, I understand that you call the patient electively to do the angiogram because you are a little bit curious to see. It's a good indication. At the same time, we're not surprised to see that the non-culprit lesion looks even worse because we know acute coronary syndromes have a very strong inflammatory component, and this may impact also the result of the non-culprit lesion, which is actually a very good indication for your next DCB case, because this is an edge restenosis of a stent, and so it's a great indication.
This is what we did,
At this point, I will read you, which is the result of this poll, which is amazing, because 92% of our colleagues would do what you did. So it seems to be a well-accepted indication to treat patients despite the acute coronary syndrome setting in a small distal vessel like this right coronary artery. Great. But now we move to, I'd say, the other extreme of the spectrum of complexity, and it's my pleasure to invite Dr. Ong to present this totally different case. And thank you, Dr. Ong, for being connected with us despite it's so late for you in your country.
So this patient, well, as you know, there's a high prevalence of diabetes in Asia, and diabetic patients have typically very diffuse coronary artery disease. So this is the angiogram of this youngest patient, 50 years old male, but he has had diabetes for about 10 years. And the patient was actually referred to the surgeons, but the surgeon thought there was no good target vessel for grafting, and asked whether we can do PCI. So if we go to the next slide. So this was in the year 2020, right? And so this is the lesion.
Yeah, well, this is the question number 2. You can see the difference. It's obvious compared to previous case. We want to ask you now, who would choose DCB in this case? We do it on purpose. I mean, this is very provocative. This is representative of the type of disease that probably is very prevalent in the southeast of Asia, like in Malaysia. And while you reflect on this question and you provide your answers, I will ask Dr. Ong to show us the technique that he applied.
So we started with the usual lesion preparation. So this will be a combination of non-compliant as well as some scoring balloon. You can see the result after lesion preparation. And we felt that it was suitable for drug-coated balloon. Well, the operator who did this case felt it was suitable. And as you can see, it was treated with 2 drug-coated balloons, one from the mid to distal LAD. We go to the next slide.
Okay,
and
but I want to ask you, address you a question that has come from our colleagues. Question number 1, is it safe to use cutting balloons to prepare the lesions?
Yes, it is. We often use cutting balloons or scoring balloons, actually. It gives a little bit more controlled type of dissection. In particular for in-stent restenosis, but we also use it for de novo lesions.
And question number 2 is, how often do you use intravascular imaging to guide your vessel preparation? And if this is a must, or you can decide to go guided by angiography?
For drug-coated balloon strategies, we often do not use intravascular imaging. However, if after lesion preparation and we need to deploy a stent for bail-out, then we use intravascular imaging for proper vessel sizing.
Okay, thank you for these very specific answers. Dayan, you want to make a comment?
Yes, Dr. Ong. It's of course a very challenging case. So of course you come from Malaysia, from a region that has much more experience with the use of DCBs in very long, very diffuse vessels. Now, when I see such a dissection, to me, it's almost a reflex, oculostenotic reaction. So when I see such a dissection, I always would go with a stent, seal it, and then stent also more proximally. What I would want to know from you and from Professor Schella as well, and you, Professor Rybikiny, is can we do something more when seeing this dissection to, in a sort of prepare our way for DCB in such a difficult subset as well? So can we do something more after seeing such a dissection to prepare more for DCB?
Who wants to address this interesting question? Bruno, are you still there?
Yes.
Yeah, as in, very briefly, your comment and then Dr. Ong's and then mine.
Number one, short comment to the question intravascular imaging. I do not think that intravascular imaging is helpful if you use DCB, because you will always see dissections and you will think about stenting. Physiology is more important, and the first look at physiology is how is the flow, how is the angiographic flow. And if you have a good angiographic flow, I think you are done. So there is no need for additional measurements or imaging.
Okay.
Number two, I fully agree that, me included, if I see such a dissection at the end of the procedure, I think I start thinking if I have to do something or not. You can leave it like this because the flow is very good. There's a lesson to learn. Or you can think about dissection modification. And in this case, it makes sense sometimes to use a scoring balloon, for example, to change the anatomy of the dissection, that it looks a little bit better for your eyes. That's what
Bruno, this is before? This is before or after you have delivered the drug with the balloon?
Ideally, you should do this before using the DCB if you see that this dissection looks not that nice, but you can do it also afterwards,
okay.
Because especially in these dissections, the drug is already delivered and it is within the folds of the dissections, and you do not create any problems when working.
Thank you. Dr. Ong, do you have, as Dayan asked, do you have any advice to deal with this dissection before you decide to remove the wire?
Well, yes. Firstly, I look at the flow. The flow is very good. Timmy through very good flow, and it's only a type B. Although it looks ugly in the angiogram, it's actually a type B dissection. Then most of the time, I will accept the result. Of course, belt stenting is not wrong as well. But if I also look at the vessel, and in this particular case, there's actually no good landing zone for a stent. Right? If you want to put a stent, you have to be either a very long stent, or it's going to be challenging. So I mean, we have to take all this into consideration, whether we want us to deploy a short stent or to leave it.
Okay.
And I think in this particular case, we felt it was safe to leave it.
Great. So I will disclose the result of the second poll, which is, again, very, very interesting. I mean, 70% of our colleagues would not have treated this patient with DCB, and only 30% are courageous enough to address this lesion like this without a stent. But the next question, the third, is after you have obtained this result, and we have anticipated already this discussion, who would leave this result? So again, vote. Tell us your opinion. This will be a shorter period because we have already addressed many of these issues. But the main, if I can summarize, the dissection looks very aggressive, very ugly, but it has been said normal flow, no chest pain, no important residual stenosis, but above all, look at the end of the image. There is no staining in the dissection. This is very important. I mean, the vessel cleans. I mean, the flow is taking all the contrast away, and I think this is a point of safety. And Bruno pointed out very, very importantly that if you put an FFR wire and your physiology is normal, this is again an indicator of good result. Of course, nobody is asking you to put a wire in this dissection again, but now we have angiographically guided physiology, which might be very, very useful in this setting. Do you have any experience using angio-based physiology in this setting, Bruno or Dr. Ong?
Yes, we use a lot now. We have the QFR, and we use it quite often now because, as I know, our center uses a lot of DCB. So now we find it very useful. Yeah, it sort of adds additional information to just the eyeballing of the floor angiographically.
Okay. Dayan.
Just a short comment following this. Would you take the wire out and give another contrast injection and then reassess? Or would this be your final shot with the wire in, which can be holding the dissection, of course?
Good point. I mean,
yeah, we normally would finish with a final angiogram without the wire.
Without the
and
wire.
it is very uncommon that we need to rewire to do bailout stenting.
And so I come back with the answers of the poll, which is quite as expected. 65% of our colleagues would not leave this result. I think that there is a need of a lot of experience to leave this, but we are very curious to know at the next slide, which is the following point and the third part and last part of our webinar, which is the long-term outcome of DCB. Bruno have shown the science, the studies, the clinical studies that have been performed, but now we are in front of real life. These are real cases. I doubt that cases like this are left stentless in a clinical trial. So, Dr. Ron, would you mind sharing with us the follow-up of this patient?
Right. So as you can see, the patient has actually has two vessel disease, but the other vessel, he decided to continue medical therapy. So has a little bit of angina on and off, but he's quite happy, with his quality of life. However, 3 years later, he was seen by another cardiologist. The cardiologist who did the original procedure had left our institution. The patient was seen by another cardiologist who felt that it was not right to leave the patient with angina and convinced the patient to have a repeat angiogram, even though patient's symptoms has not actually changed. And what you see here in this slide is a repeat angiogram 3 years later. And you can see that there's preservation of the lumen in the LAD, and the dissection in the distal LAD has almost, well, I would say has completely healed. You might see a faint white line there, but I think that is the ridge left behind by the healed dissection. So this is the baseline, the angiogram after lesion progression, after DCB. You can see the dissection, and 3 years later, the dissection is healed, and you might even convince yourself there's some positive remodeling. There's a gain in lumen diameter, both in the proximal as well as in distal LAD.
This is impressive. Certainly, the long-term result is much more important than the immediate. But even though we have some questions for you that are coming from our colleagues, one of the questions is how long you keep these patients on dual antiplatelet therapy or any other kind of antithrombotic regimen?
This patient actually presents acute coronary syndrome, so the antiplatelet therapy for him is 12 months. But however, if this were, let's say, elective case, a non-ACS case, despite the dissection, most of the time we only give dual antiplatelet for 3 months.
Okay.
Because we have done quite a number of repeat angiograms, and we find that by 3 months, most of the dissections have healed.
Another question is, provided that you discharge the patient the day after the procedure and you know that there is an important dissection, do you restrict physical activity or you let the patient perform regular activities and including effort? He is a 50-year-old person, so we all suppose that he works or he exercises. Which is your policy?
No restriction of physical activity at all. And in fact, a lot of the patients who are actually done as day case, they actually get discharged 6 hours after the procedure. But of course, if you are at all concerned about the dissection, the extensive dissection, occasionally we do keep the patient overnight and discharge the next day. Yeah, but a lot of these cases we actually discharge on the same day.
Okay. Thank you very much. Another question from our colleagues. After you have used a drug coating balloon and you decide to implant a stent, probably, hopefully in a spot area, would you decide to use a bare metal stent or a drug-eluting stent?
I think
Professor Scheller, maybe you'd like to answer.
No, I think the answer is clear. You should use a limus eluting drug-eluting stent.
drug. No concerns about changing drugs? You have used paclitaxel in the balloon and you will use Elimus in the stent?
No, not at all. The opposite is the case, because you do not create toxicity because you have two different modes of action, and a cell that is already blocked by paclitaxel can't be blocked in addition by sirolimus. So I think that's the way to go with different drugs.
Very well. Thank you, Bruno. Dayan, this goes to you because the colleagues are asking, would you consider using a DCB in a side branch, in a bifurcation, or even in an OCLC-X after stenting left main LAD?
Yeah, that's a big question. The problem with the DCB and let's say a default strategy with DCB with bifurcation is that the current recommendations are not to predilate. The current recommendations are such that you place the main vessel stent and then intervene on the side branch by kissing balloon inflation, for example. Now, in case of DCB, you would need to prepare first. So basically, with DCB, the sequence of steps might probably be a bit different, where you implant the main vessel, and then you would have to prepare the side branch with the balloon, but that is adequately sized, and then a kissing balloon, and then you would have a DCB to the side branch, but once again, you may need to have simultaneously the balloon in the main vessel. All this remains uninvestigated. So I would say for now, it depends on the anatomical circumstances. But I would like to hear the opinion of Professor Scheller as well, because he knows the kinetics of the drug release and the interaction with the balloon better than all of us. So what is your opinion on this? I mean, can we proceed as just I said? Can we do simultaneous balloon inflations with a DCB and the plain balloon in the main vessel stent?
I wouldn't do this, and that's really one of the part you mentioned the big discussion with EBC and the DCB protagonists when discussing about a randomized trial on bifurcations. And at the end of the day, the consensus is that you have to define your strategy first. And if you, as you say, use the DCB strategy, you start with predilatation both branches sequentially, and then you use first the DCB in the side branch, then you use the DCB in the main branch, and hopefully that's it. And if you have to do kissing, you have to do this with plain balloons, which is also a used DCB balloon, is then a plain balloon. So that's it, but don't do kissing with DCB. Okay. It makes no sense because you have a very limited drug transfer in several areas of it.
I think that's an important input because it's an ongoing discussion. So first, you need to be clear about the strategy of your bifurcation before deciding on the use of DCB. As Professor Scheller said, if your strategy is that you are going to predilate the side branch first and take care of the side branch first, then the DCB is an option. But if you go by the way that we usually do, and that is not to touch the side branch until the main vessel is already stented, then a DCB option might be a bit different or problematic in as much as you are not encouraged to do the kissing balloon inflation.
You are raising a very important point, and I can anticipate that there is an upcoming document with this, which is dedicated to this. It's a consortium agreement in between several experts, among, of course, Bruno, and this has been addressed. And another piece of advice I want to share with our attendees today is that the PCR textbook has opened freely the chapter dedicated to DCB use. I don't know if especially because of this webinar, I want to think so. So you can all consult this fantastic textbook in this specific setting for free from today. Well, I think we are approaching to the intermediate indication to use DCB. We move from a simple low-risk situation to a very complex and high-risk LAD performed in Malaysia. But now let's go to some more normal things. And what would you do in case you want to treat this patient? Please, Bruno, present these patients of yours, and let's discuss on a more normal angiographic situation.
This is a case which is very interesting. This is a physician colleague, a 56-year-old female. She had newly diagnosed hypertension, no other risk factors, and she did extreme exercise in the Alps, and she felt for the first time in her life shortness of breath and atypical angina, and there were some salves in the stress test. And the CT scan, as you can see, showed a proximal LAD stenosis. A scenario, I think, where most of you would say, okay, proximal LAD, what's wrong with putting in a drug-eluting stent in this situation? She is oncologist, and she has a very positive attitude to paclitaxel because she knows this drug very well. And she said, okay, can you do it without a stent? Can you use a DCB? I said, okay, I can try it.
Well, we will address this question to our colleagues because this is totally different. This is a big vessel. It's a relatively focal lesion. I mean, there is nothing wrong putting a stent there, but of course we are trying to do something different. And so the question to our colleagues now is who would consider using DCB in this specific case? While you vote, we keep on showing what you did.
I did, of course, DCB, as you know. I started with, this was a relatively soft lesion, type A or B1, and I started with scoring balloon, what I'm always doing, and I used only a 3.0. I think if we would have done intravascular imaging, for sure we would have seen that this is a 3.5 vessel. But I started with a 3.0, and there was a type A dissection, and so a good flow, and so I used a 3.0 15 paclitaxel coated balloon, what you can see here. And next slide, you can see that after DCB, there is still some dissection, some haziness, but we have a good flow. And what's also important, you have to look at least in two projections to define the grade of your dissection. And that was the end of the procedure. And a few weeks later, she started again doing exercise training.
I think this is a very nice case. It's an excellent example of a simple lesion that behaves as we all wish a lesion can behave, because yes, it's right in the lower part of the vessel there is a small dissection, but this is a type of dissection that we should never stent, I would say. There are questions from the audience. In case you want to test this with physiology, because it's about a proximal LAD, it's a young patient, and it's a colleague. We all know that doctors are the most dangerous patients we can treat. So you want to make sure that you are discharging these patients safely. The question is, which is the threshold for accepting a good physiologic result, Bruno?
Let's say for me first, as I said before, the flow, the angiographic flow is the most important factor. And if I see that there is a very good flow, as in this case, for me, there's no reason to additional measurements.
But if you want to provide a cutoff of FFR, IFR, or QFR?
Yeah, if you look at FFR, we are at the moment using the same cutoff as with stents, 0.8. Mm-hmm. But there is room for research in this area. There are groups saying 0.75 is enough because you have an improvement over time, also of the FFR, not also of the lumen. Other people say maybe if you want to be on the very safe side, 0.85 could be the threshold. So this is an open question.
Okay.
We are using 0.8.
Which is the follow-up of this lady?
She underwent CT angio 6 months later, and this is the result on the right. Mm-hmm. And what you can see is there is still some calcification in this vessel, but you don't see any signs of atherosclerotic plaque in this DCB-treated area anymore.
It's really impressive. I mean, it's also impressive the quality of the CT scans of your center. Mm. This, I think, completely replaces invasive angiogram. And I think it's an extraordinary case. And to my surprise, I have to confess, now I will show you the results of the last poll. The question was, would you use DCB in this case, this proximal type A lesion of the proximal LAD in a young lady? Dayan, which is the answer? Guess. Yes or no?
No. Well, since you said to my surprise, it will be yes.
No,
It's no.
my surprise, because I would have done the same that he did, but 77% of our colleagues would not treat these patients with DCB. Of course, the use of stents in these large vessels, so small lesions, are very good. But still, there is a 22% of colleagues that would have considered. But the majority, by far, would not have treated these patients. But look at the angiogram, at the CT scan at 6 months.
I mean, it's still anecdotal evidence, and I think this webinar might be different from other similar sessions in as much as we really show the follow-up of all the patients. And I think this needs to continue, that the patients that we do for this clinical or that anatomical reason with the DCB are followed up with angio, so that we can share among the peers how the follow-up looks like. And of course, here on the CT scan, it really looks nice. So this, it can be understood that such cases can then be translated into positive evidence down the road. But until we have the evidence, I think that most of the peers for a proximal LAD would say that the stent is the first option. Of course, you may have clinical reasons for not doing so, and I think this was one example for that.
Okay. One question from our colleagues is, can we stop dual antiplatelet therapy after 1 month? Who wants to address this question?
We are doing this on a regular basis, and this was also the regimen, for example, in BasketSmall-2 trial. The non-ACS patients underwent only 4 weeks of DAPT. It is unclear if we need this 4 weeks. Maybe, as Dr. Ong said, 3 months will cover the time until every dissection has healed. The question is, do we need to cover this time? Antonio Colombo, for example, says, okay, 2 weeks is enough. We do not need more, because the risk for thrombus formation within these dissections is gone after 2 weeks. So we do know this exactly. Our approach is 4 weeks.
Okay. 2 questions for our expert from Southeast Asia. Is it useful to wait 5 to 10 to 15 minutes without the wire in the lesion in the lab to wait and see what is going to happen? Is that a predictor of safety, or has nothing to do, Dr. Ong?
No, we don't routinely do that. However, if you have a dissection that you are a bit equivocal and you are still a bit concerned, then we wait for 5 minutes and repeat the angiogram. But for the majority, more than 90% of our cases, the moment we remove the wire, we do a final angiogram, we're happy with it, we end the case. Yeah, we do not wait for the 5 minutes.
Okay. Another very practical issue, is it useful to leave the balloon for more than 60 seconds?
No.
I mean the drug coating balloon?
Yeah, no, I don't think so. You know, in the animal models, we have the full transfer within 10 seconds. If you use it for 30 seconds, you will have almost the full transfer. Maybe another 30 seconds are beneficial, but not longer.
Okay. Another question, very technical issue. I would address this to Dr. Ong. Can we use DCB after lesion preparation of calcified vessels with rod ablation?
Well, there's no studies looking at that, but at our center and a few other people's places as well, we have used it. And I have a few cases where I have angiographic and intravascular imaging follow-up, and I get good result as well. So I think my impression is that for calcified lesions, if the lesion preparation is good and the result is fits all the criteria for an acceptable angiographic result, then DCB can also be used.
So it seems that DCB can be applied in a very wide range of clinical and angiographic situations. So I will address another question, which is a little bit tricky. Would you treat ostial lesions with DCB?
It depends on which ostial lesion it is. Ortho-ostial disease requires stenting. Ostial right, ostial left main require stenting. But all other lesions, ostial circ, for example, can be treated with DCB.
Okay, so you would avoid the aorto-ostial lesions, which are very fibrotic, very resistant, where we need a very strong stent with radial force. Good. And another nice question, I would address this to Dr. Ong. How often do you perform elective angiography after DCB?
Well, we used to do a lot in the past, but because we get positive results. All of them shows good result, no restenosis, positive remodeling, healing of dissections. So now we do not routinely do a follow-up angiogram. Unless the patient has a stage PCI to another vessel, then we will have a look at it, but not routine anymore because we find no benefit. It's always good. The result is always good.
Okay. Dejan, a colleague I know well in Argentina, Cesar Vigo, is asking, what happens if you notice there is elastic recoil and you keep on dilating and there is recoil after you use the DCB? Would you leave it like this or you stent?
Yeah, the question is, why do we have a recoil? So probably after I notice a recoil, I would do intravascular imaging to understand what's happening in there and to see whether I need to do a plaque modification and then proceed further. I would like to know what is the cause of the recoil. If it's undilatable lesion, I would like to know whether I can prepare it better.
You know, this has happened to me several times. Sometimes you look at benign lesion, you dilate and you don't get a good result. And you try with the DCB and you don't get stenosis, residual stenosis lower than 30%. And actually, I don't go with IVUS. I really put a stent and finish the procedure because recoil sometimes is difficult to be identified by IVUS. Sometimes there is no calcium. It's just the elastic vessel that drops into the lumen. So I think we have had a lot of questions. It's very nice to see all this interest, and we were able also to address most of the cases we wanted to show to our colleagues. Of course, there are questions that are repeated. I mean, I think there is a lot of interest regarding the need for using intravascular imaging. We didn't address the fact of using OCT, but as Bruno said, and this is also in my own experience, the more you see, the less you want to use DCB. Because, of course, the vessel to be dilated, to be properly prepared, needs to be expanded. And the intima is a very, very delicate layer of the vessel. So you will always see dissections. And the more you look at them, the less you will like it. So I personally try not to use intravascular imaging when you, of course, before planning the strategy, if you have calcified lesions, if you want to understand whether it is a 1-1-1 Medina bifurcation or something different, before it's okay. But to assess the final result, I think it's good that we underline what Bruno and what Dr. Ong, what we have been discussing, no chest pain, good flow, no ACG changes, dissections without staining contrast on it. You can wait a couple of minutes without the wire in the beginning, but something which is very important and what to underline, the incidence of acute occlusion and acute thrombosis, this is written in the articles, it's higher with stents rather than with DCB. And this is very important because when I go home and I leave a dissection like the one we have been showing before, each time that the telephone rings, sometimes I think they are calling me because the patient has an ST elevation in mind. And actually, I have to say this is very, very infrequent. While it happens very infrequently also, but there are stent occlusions because of thrombosis, especially in the growing population of elderly patients who are high bleeding risk. I mean, patients high bleeding risk are an ideal population to go with this technology. So if you don't have any additional comment, I will wrap up with some conclusions that have been shared with my colleagues that very generously dedicated their time to the preparation of all the material that we have shared, but also to the conclusions. Since the early 90s, we have been implanting stents. And 10 years later, we started implanting drug-eluting stents. But after more than 40 years, we are doing the same thing. So if you want to think different, we have to think about an alternative to metallic stents. The attempt of using bioabsorbable scaffolds was a good idea, but the long-term results were not that good. A different medical practice would be transforming a diffusely infiltrated atherosclerotic conduit into a well-functioning anterior vessel wall, and not into a diffusely infiltrated metallic conduct. I think this is a very important message. We have learned that full metal jacket sometimes is necessary because of impending or abrupt vessel occlusion. We have to save the patient muscles, but this will preclude surgical interventions in the future, and this is related, as we well demonstrated, to very high rate of severe events, mortality, infarction, and thrombosis at the long term. So behind this thought, the use of a different medical practice is treating coronary artery disease, obtaining a normal, I would say, normal-looking arterial wall. Allow me this almost normal arterial wall without metallic struts, without foreign bodies, with an almost normal vasoreactivity, or at least with the possibility of moving. It's not a caged conduct, with free bifurcations. This, I think, is very important. The side branches are not obstacled by these struts, and with less stimulus for neoatherosclerosis. Atherosclerosis happens with age, but there is no permanent stimulus. And with room for future and yet unknown forms of therapy. We don't know what we will be doing in 10 or 20 years. What we know is now we have a device to think different. I hope you have enjoyed this webinar. By the questions we got, we think that you were rather engaged, and this is thanks to my colleagues. I want to thank Dr. Ong, Professor Scheller, and my friend Dr. Milasinovic, and all of you, and PCR for giving this educational opportunity, and also Medtronic for this unrestricted grant. Wish you a very good evening, and to see you again at the next PCR webinar.
Thank you very much.